the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. This week, we continue our conversation with Dr. Robert Baranello in Strategies in Interventional Pain Management. So the second objective, you talked about the evidence that supports neuromodulation as a safe and effective treatment. Do you have any information you can provide our listeners on that? And then the flip side of that is, are there contraindications to using this? And I think that probably ties into the third and last objectives about patients, selecting the right patient. So anyways, I was hoping you might chat about that.
I would say far and away the most common neuromodulation therapy is spinal cord stimulation. So sometimes I use them interchangeably. So forgive me for that. But in a lot of ways, we've known about this physiology since the 1960s when Melzack and Wall came out with their gate theory of pain. The idea behind that is we have all of these different nerve fibers in our body. Some of them are pain specific and some of them are larger motor neurons. Some of them have our protective myelin sheath around them. And one particular pain fiber, they're called C fibers, are quite small and slow and unmyelinated. And so the idea behind this gate theory, and again, the idea behind some of our neuromodulation strategies is, I use the analogy of rubbing boo-boo, right? Say you bump your toe, or maybe you have a toddler who bumps their head on a coffee table, something like that. By rubbing, you actually recruit these larger sensory motor fibers. And by recruiting them and sort of outcompeting those smaller pain fibers, you're actually outcompeting for your brain and spinal cord's attention. And so by doing that, you're actually essentially inhibiting pain fibers and the painful stimulation as it gets sent up to the thalamus and sensory cortex. So that is primarily the idea behind what we do with a lot of the neuromodulation strategies. As far as evidence goes, again, we've known about this physiology since the 1960s, and some of the earliest, quote unquote, implanted neuromodulation strategies was done in a very open neurosurgical, frame of reference. But now as our technology and devices have sort of caught up with our understanding of the physiology, we've been able to really dial this into quite a minimally invasive approach.
Or contraindications in patient selection, how do you decide? How do you go through that process?
That's a great question. This was something that was certainly stressed upon me during fellowship more than anything else. Patient selection is absolutely the cornerstone of efficacy in the utilization of this neuromodulation space. We definitely want to make sure that, certainly we're picking the right patients for these strategies. Of course, we want to make sure that first and foremost, that patient has an indication for the device. So again, like we mentioned, that could be post-laminectomy pain syndrome, complex regional pain syndrome, or painful diabetic peripheral neuropathy. The workup includes getting a lumbar and thoracic MRI to make sure that there's no compressive pathology that would potentially get in the way of us placing the actual device. The leads that we use, the stimulator array leads that actually does the stimulation, are quite small. And again, for me as an interventional pain specialist, I do all of these trials and implants percutaneously, but there is a whole other space that orthopedic spine and neurospine surgeons can perform in a more open with a laminectomy approach. So as far as patient specific selection criteria, we want to make sure that, of course, we have tried and potentially failed many of our other more conservative therapies. I'm sure a lot of people who are listening to this podcast are very aware of sometimes some physical therapy and some core and low back strength exercises, gabapentin or pregabalin. Some of these anti-neuropathic pain medications can really make a big difference. And so we really want to make sure that we are reaching far and wide into our toolbox before we dig into some of the more invasive procedures, such as these neuromodulation techniques. The other thing that's, I think, paramount in considering moving forward with the neuromodulation technique is the role for surgical intervention. So, of course, with something like a painful diabetic peripheral neuropathy, that is certainly not something that you can excise or remove, of course. But sometimes these patients who have had back surgery before may have some degree of adjacent segment disease. So imagine some spinal stenosis, central canal stenosis above the level of their prior fusion. That's certainly something that you want to keep an eye out for. And potentially that patient may need an extension of that laminectomy or fusion before you consider neuromodulation strategies. I think the other thing that's extremely important to consider is what the patient really wants. Maybe the patient's not a good surgical candidate, so that's certainly an option. But sometimes the patients don't want surgery. I've had patients before who I do send to the spine surgeon and say they do have adjacent segment disease, and there is a new disc and some central canal stenosis there. But when given the option, the patient chose to pursue spinal cord stimulation trial, and we're going to move forward with the implant in another couple weeks. So making sure that we're making a patient-centered decision about this is also very, very important. Some of the more technical things to consider, you obviously want to make sure that you get a good detailed history, whether or not patients have a history of postoperative wound infections, such as MSSA or MRSA, that might change your antibiotic strategy, or whether or not to implant that device to begin with. If they have something like diabetes, either for peripheral neuropathy or, say, for post-laminectomy pain syndrome, you want to make sure that their blood sugars are well controlled and that their A1C, I would say, for the most part, I think people are probably looking at less than 8 as long as it's been well controlled. But the lower, the better, of course.
And then you find, okay, this is the right person. You do a trial before you actually do the implant to see if it's going to work. Listeners, stay tuned next week when we continue our discussion with Dr. Robert Baranello in Strategies in Interventional Pain Management. The PAOS annual meeting is in Nashville, September the 2nd through the 6th. Get yourself registered and get your room reserved, and I hope to see you there.